Hello, welcome to my presentation. My name is Thomas Beers, and for the next 4 hours, we'll be spending together. Not just kidding, everybody just kind of like, whoa, what? That's not what my agenda says. Hi, my name's Tom Beers. There'll be lots of surprises like that throughout this presentation. And I just thank you very much for taking the time to visit, to step in to this virtual room and take a listen and I gotta admit, I kind of cheated a little bit and hopefully drew you in with an amusing title, Running Lights and Sirens Towards the Abyss. And it's supposed to elicit a response. This will be for some of us, a very uneasy conversation. And I'm hoping to give some insight into the current state of EMS without any puff piece here. This is going to be a tough conversation. History is repeating itself. In the 1970s, fire departments found themselves in a very difficult position, right? Improvements in civil engineering and code enforcement were leading to a decrease in the occurrences of fire in the United States. And so chiefs and administrators of fire departments were looking for a new role and for their firefighters in order to save jobs and keep the community safe. And they saw a real need for emergency medical services. And so they adopt that. But since then, in the past 40 years, since the early 70s or mid 70s, when EMS really started taking off, EMS has become a financial behemoth, both nationally and locally, and has turned into a catch-all for medical issues, many of which are not emergencies at all, taking out the term or the title of E in EMS. And this burden on frontline healthcare is draining the very limited resources of EMS services across the nation. So just a few years ago, we were at a crossroads. We had the advent of the Affordable Care Act, and we heard all these great things that the Affordable Care Act was going to do for EMS, that it was going to make us data-driven and result-driven, not financial-driven, based upon archaic principles of you call and we haul. We're going to dive really deep into that. But we thought, okay, this Affordable Care Act is to make EMS an essential component of the medical community. And we are about to go through another election. We have seen that term of executive power come and go. And EMS is exactly where it was 10, 15 years ago. Sure, we have POCUS. Sure, we have CPAP. Sure, we made advances in medicine. But I'm not talking about medicine. I'm talking about systems improvements and systems efficiencies. And we have coined this term, community paramedic, and since the Affordable Care Act, even slightly before we knew this was coming, it's gone through several iterations, mobile intensive healthcare, advanced practicing paramedic, and we've, as an industry, have kind of settled on CP. Not my favorite. I liked advanced practicing paramedic, but this is what we have, this idea of community paramedicine. So this presentation is going to examine, really, if we knew this was coming, why isn't it everywhere? Why isn't everybody doing it? There have to be some barriers and misconceptions to the barriers of what a successful community paramedic program looks like, and even what a community paramedic program is supposed to look like. We all have some strange ideas out there, but no one's really looked at it nationally. Are we all talking about the same thing when we talk about community paramedicine? Because many of us feel that it is an answer to fix what many of us are considering, but are too afraid to ask or state, until now, hopefully, that we have a fragmented and broken EMS delivery system of care in this nation. So who is this blasphemer that is stating all of this that we don't want to talk about? Well, let me introduce myself to you. A little bit about me. I am a paramedic and firefighter for the city of Cleveland Heights. I've been involved in EMS for over 25 years. Started off at the University of Dayton, volunteer rescue squad. Worked for the city of Dayton for a while before settling up into the Cleveland area with my family. I am also fortunate enough to be the EMS manager for what some would argue is one of the premier healthcare agencies in the United States, if not the world, and is a leader in healthcare. And I act as the voice for frontline public safety responders, both EMS and fire-based EMS, third service, and law enforcement as they dive more and more into EMS under critically extreme circumstances. I'm also a U.S. Army veteran. I enjoy volunteering with Team RWB, which is a veteran service organization that uses community service and athletics to engage veterans and to make them more integrated into their community. Again, like I said, I'm a graduate of the University of Dayton. I also have a master's degree from Anna Maria College, just outside of Boston. I also act as a special envoy for the Principality of Sealand. And finally, and most importantly, I am a husband to my beautiful wife, Megan, and a father to 4 boys. 2 are my stepsons and 2 from my first marriage. And so I am always looking at a way to make the world a better place. And sometimes that is saying and having some very difficult and uneasy conversations, which I'm hoping that this will be. And if 100 people watch this presentation and only one of you walk away with a changed mind, then again, with 25 years in the fire service and with Department of Defense and the U.S. Army, you pick up a few terms. And one of those that is my favorite is 1 is greater than 0. So if just one of you walks away with a changed perspective, this will have paid off. The other 99, you can get a refund at the door. So I think for some of you, you're not even paying for this. And going back to Sealand as a special envoy, yes, the Principality of Sealand is real. And just for $249.95, you too can own a wonderful piece of this independent nation just 7 miles off the southeast coast of Great Britain. But that's a story for another presentation, but that is my dual citizenship, and yes, it is real. That is the nation of Sealand, in which I am a special envoy to the United States for Prince Michael. That's real. Let's get down to brass tacks. What are we talking about? So in 2019, I completed an extensive research project for my master's capstone thesis that really I wanted to look at community paramedicine and focus on kind of what I precursored this with. What are the misconceptions? What are the barriers? If we knew this was coming, if we thought this was going to save what many of us believe is a broken EMS system, and none of us want to admit to it, then why aren't we all jumping on it? What are the barriers? What are the realities? And if we're talking about community paramedicine, what is community paramedicine? Are we all talking about the same thing? Because if you open up any GEMS magazine or EMS World or Read EMS One or a variety, NAEMSP journal, community, there's not one community paramedic program that looks exactly like another. And that's probably by design, but it makes it very confusing for many of us to really put a tack into it and say, well, that's community paramedicine right there. But that over there, that program is not. And we're going to explore how those become barriers to adopting community paramedic programs. So this was a research project I did for my master's thesis or my capstone, and you make these pages, you work so hard on it, you think, man, no one's ever going to read this. And so I thought, being that social media has a level of narcissism to it, I thought, well, my stuff's good enough. I'm going to put it online for people to read, because most journals won't accept 49 pages of data and analytics. So I think I published it on Scribd.com and tagged it up on my Twitter feed. And Robbie McHugh was crazy enough to actually sit down and read it and go, hey man, this is something. You should present this at our EMS Leadership Summit, which is virtual. I was like, oh, really? Okay, if you think people will be interested. And he thinks you are interested. So if some of you fall asleep or turn this off, again, you can get your refund at the back of the door. And so this is really examining the research project and kind of sharing you some very interesting findings when we talk about community paramedicine, and thus the title, Running Lights and Sirens Towards the Abyss. Because if we don't, I want to give a visual presentation, like we're running lights and sirens and we're driving towards a cliff and we're not willing to address that as an industry. In some places, they don't see it. And other places clearly see it. And there's a whole bunch of us that are really indifferent for a variety of reasons. And we're really going to get into that. But just like EMS saved the fire service, community paramedicine is supposed to be saving EMS, whether it's fire-based or third service or even hospital-based or private for-profit based. And so just like any good research paper, you have to have a solid research question. And I'm not going to read many slides, but I am going to read this one so you understand the veracity of what we're trying to capture, the overarching theme here. And so the question is, can community paramedicine address the needs of EMS agencies by reducing local healthcare system costs while bridging the gap of healthcare access for society's fringe populations and vulnerable populations? And if so, what are the current barriers and misconceptions to establishing these types of programs that we're calling community paramedic programs? So when I say reducing healthcare costs at the local level, I'm not talking about within your silo of your jurisdiction, right? I'm not talking about within the silo of my city versus the silo of the next city and the next city over. I'm talking about the healthcare costs to the aggregate region, right? To Northeast Ohio, to Greater Dallas, to upstate New York, wherever you might be from and listening, not just your local jurisdiction, but your local region, which is very different. And if we can reduce those healthcare costs, it's not the same as saving money. Okay, there's a misconception. They're like, hey, this is not saving me money. Yes, but it's also because you're not spending enough that you're going to be more well off in the future. So we're trying to reduce local healthcare system costs by one community at a time. But at the same time, if we're reducing costs, how can we meet the needs and obligations of those most vulnerable populations in our communities? And we all have them. Even, I don't care if you're working for a community whose median household valuation is $300,000, and most people work on Wall Street. There are vulnerable populations, whether it be by age, by race, by medical literacy. They are there in your community. There is a have and have not within your community. And so when we look at what all of that means, this crossroads within that question, we're looking at two things, and really it's driving back to here. It's money and ethics, and these are two things that never should be mixed, right? Money is the root of all evil, and yet we're going to try to cross it with some type of ethical equation of being able to distribute and save healthcare dollars and monies so that we can have some type of equity across the board. So what do I mean by money? The financial outlook. From a financial outlook, this research project really, we're examining the burden of the unmet medical needs not addressed by the current and pervasive you call, we haul system. Let's face it, you call, we haul, that's where, if you're not familiar with the vernacular, we use it up here quite a bit, is many administrators say, someone calls 911, I don't care how little the complaint is, you go ahead and you transport them to the hospital. And so we call that a you call, we haul, and it does not address the medical needs of the vulnerable and the unmet medical needs of within that system, within that type of structure, because really it's unsustainable. That tap of water, of money, from the federal level and from the state Medicaid level and from private insurance, that tap is getting turned off if you haven't felt it already. It is not, and even if it wasn't, that money just it's not going to be there forever. We can't rely upon that. And how big of a problem is this? $5 billion. These are 2014 dollars. And at the end of this, I have all this cited, and I'll share all of this with you. So none of this that I'm putting up here is really. I guess some of it's opinion, but it's based upon some really good, strong research. And I guess, if anything, this is a persuasive presentation. I'm trying to change your mind what we're looking at. So that $5 billion is what Medicare paid alone to municipal 911 EMS services. And I think I just saw this recently, maybe within the past couple of weeks, NAEMSP's journal just had a study in there that showed that I think it was 9%. And thank God we're not doing this live and someone can just raise their hand and correct me, but I believe it was somewhere like 9% of EMS trips to the emergency department really didn't meet the threshold of an emergency and really could have been handled somewhere else outside of the emergency department. So we're wasting $5 billion. And again, that's just Medicare. That's not including Medicaid at the state level and private insurance. So imagine how many billions and billions and billions of dollars we're wasting on a archaic and broken system of you call, we haul. And really what it comes down to is a scheme. And you can take that word not in such the negative light that it usually gets when you say scheme, but it's an incentive scheme that is quite upside down. Why would anyone treat someone at home when they could get paid to take them to the hospital? And that is where we get into the ethical question. Can we do what's right for a patient by not taking them to a hospital, by sending them to more appropriate resources? Because on the ethical level, that research question, it's even really more important to examine. So I'll give you a case in point. All right. Despite Cleveland Clinic being, as good as it is within the healthcare market space, right within that neighborhood is some of Cleveland's most impoverished people. And within it, the life expectancy hovers at about 70 years of age. Meanwhile, just about 10 miles away in another town called Pepper Pike, the life expectancy is 82 years. So imagine the difference of just 10 miles. 10 miles will change your life for 12, will give you 12 extra years of life. That's 12 years with your grandkids. That's 12 years with your kids. That's 12 years to travel. And 12 years just to enjoy life. And all of that disparity really arises from a multitude of socioeconomic factors, include access to healthy food choices, because we have food deserts, gyms, parks that aren't filled with violence or drug pandering. And even the schools within these socioeconomically depressed areas produce populations that are not as medically literate. And that all plays into, over an aggregate time of a lifespan, the difference of about 12 years of life expectancy. So in this environment of disproportionate access to the full spectrum of healthcare needs, EMS has become this safety net that it was never designed to be or intended to occupy this role of being, you call, we haul. No matter what it is, someone will come and pick you up and take you as fast as they can through traffic, more important than everybody else, to go get, I don't know, right now, a COVID test, right? Does that really constitute an emergency trip just to get a test because you might be exposed? That's a really good way to look at it right now. So that whole idea that emergency departments eventually become overrun with EMS patients that are who are not really exhibiting emergencies and meeting that threshold and could be treated on scene by EMS professionals and as more, or even by mid-level practitioners, or maybe a new type of paramedic, an advanced practicing paramedic, a community paramedic, if that's the term we're settling on. And for this, we're going to say community paramedic, and I may say CP from time to time as I speak. Who can make decisions to help people make better decisions on where they want to go, and even transport them to more appropriate facilities like addiction centers or mental health facilities. I mean, imagine of that $5 billion, how many of those were for secondary trips that 911 services took someone to the hospital because they were having a psychiatric episode, not a harm to themselves or other people, and then a private ambulance company came and picked them up and took them to a psych hospital after they were deemed to be medically stable, which essentially assists of, are they breathing, and do they have a pulse, and are they going to hurt themselves? I think any paramedic can tell if someone's alive, has a blood pressure, has a pulse, and can or cannot be a harm to themselves, at least until they can get to a mental health facility. And there are models in this country that transport directly to mental health facilities, and we'll talk about that. And on top of all of this more and more people call 911 for services that we were never designed to do. We have this silver tsunami, and if you have it coming, we're in it right now, actually. And if you are not familiar with the silver tsunami, I first picked it up from Ray Bereshansky, who's out of Pennsylvania, a prolific speaker. I'm sure many of you have seen him, and I'm fortunate to call him a colleague. And I don't know if he coined the term, but he definitely brought it into the EMS vernacular. And what is silver tsunami? It's this phenomena from the 1940s, the the baby boomer generation that started then, they're now they're the largest population baby boom, largest surge of population here, and they are now from the 1940s to now they are now becoming medically defined as geriatric, meaning over 65 years of age. And with age comes a number of health care concerns and chronic illnesses. So again, there's that hint. It doesn't matter if you have what the level of income is in your community, you're going to have older people who are going to rely on EMS more and more for their chronic health issues. So that's really, again, what we're looking at is the crossroads between money and ethics. And so again, that's an overarching theme that we'll keep coming back to, but I also want you to constantly think as we're discussing in those two. Just imagine in your head a balance, a scale. And on one side you have the money equation, on the other side you have the ethical, the other side of the equation, which is ethics. And you have to balance these two out if you're going to have any type of successful conversation or fruition of a project that involves some form of community paramedicine in the future. And we'll talk more and more about what that kind of looks like. So, there's a saying that if you've seen one EMS agency, you've, seen just one EMS agency. They're all different. And the same is for community paramedicine programs. I'll give you a couple examples. And it's when we talk about like a community paramedic program, I imagine that most of you in your head have a vision of someone in a Tahoe or a personal vehicle or a car that goes out to older folks' homes and helps them do medication consolidations and maybe trip and fall hazards. And that's fine. That is not community paramedicine, though. That is a form of community paramedicine, but is not the definitive concept of what community paramedicine is. CP comes in an array of different forms, and I'll give you a couple of examples for you to think about. And while I'm reading, you tell me if it is or is not. Think about it. Is it a community paramedic program? What about this? A blood pressure screening program and blood glucose monitoring program where every Wednesday the local fire department goes to the senior center or senior centers in their town and where folks are have different ethnicities or immigrant populations or in socioeconomically depressed areas, and they give free blood pressure screenings and blood glucose readings, and at the same time they pass out literature from the local hospital and the health district about lead paint mitigation, what is sodium, right? Versus like I've actually met a patient who said, well, you're not supposed to take so much sodium, salt, and they're like, well, doctors didn't say anything about salt. They said sodium, again, going back to medical literacy, right? And so to be able to connect with them in a way for a few guarded hours a week to do an easy task, some blood pressure, some blood glucose readings, and then pass out some literature to help people make better decisions about what 911 is for and educate them what 911 and connect with them and educate them about proper uses of 911. That is a community paramedic program. Absolutely. It meets the needs of that community and it scales it to that small fire department that does that. The department does this as a one station department, probably covers about 6 square miles. But for them, that works because it's their community. It meets the needs of their community, thus the name community paramedicine. What about this one? A medication and prescription assessment and reconciliation program. Like there's one out of Colorado. And a paramedic, this is more of the traditional that you think of community paramedicine. Someone goes around, they meet with their frequent flyers and they help them select better options on their medications and drugs and consolidates them between different physicians and different maybe healthcare and public healthcare agencies that provide those resources to them so they can make so they're not crossing medications or that shouldn't be mixed. What about field-initiated scripts, right? So prescriptions. Someone calls for, and this, I'm not trying to make a funny example, but an STD. Where I'm at, that people call 911 for STDs all the time. And you know what we do? Our chiefs say, you call, we haul. Okay, we take them to the hospital. They called for service, we take them. But what a waste of the healthcare system. At the micro level, sure, fire department gets a little bit of money for it. But the macro level, the regional level, it's costing the system and all of us out of our own pockets as taxpayers a considerable amount of money for something that, yeah, it looks like, I won't say smells, it looks like, and from what you described to me, like you have a sexually transmitted disease, and the history of how you think you got it sounds like a sexually transmitted disease. In a field-initiated script program, the paramedic calls up the doctor and says, yeah, the guy says this, guy says that. Doctor can or cannot talk to the person maybe if he wants to, or takes the paramedic's word on it, just like a PA would in the hospital. He's taking the paramedic's word on it in the street, and the paramedic says, and they're allergic to penicillin. And the doc goes, okay, we'll give them, XYZ or a Z pack, right? Something for this STD. And my goodness, all of a sudden there's no hospital bill, there's no EMS bill to the taxpayer or to the private insurance company. What about a suturing in place program? If you could teach paramedics to do sutures in place, which we can, it's been proven, to recognize those that need plastics or more extensive exploratory look from a physician, sure. But for most part, many lacerations could be handled by a paramedic in the field, specially trained to handle. And my goodness, what about someone who fulfills many of the roles I've already listed, right? Prescription refills or prescription administrations, suturing in place, helping people make better decisions. So a suturing in place type of thing would just be another trick that a community paramedic would fill many roles could actually have. What about, I think it's Wake County, North Carolina? Again, a leader in this industry that has an alternative transport for mental and substance abuse patients, right? Rather than take them to the emergency department, we kind of talked about that earlier, just take them directly to a facility that would meet their needs other than the emergency department. I think it's San Diego has a care of transient, and I think it's called the Cotton Program, care of transient and those in extreme need, I believe is what the acronym stands for. And that is, it's a collaboration between faith-based groups and public health and social service and warming centers and homeless shelter capabilities, soup kitchens, crisis intervention, even veterans assistance programs, dental services to help people that are really the most vulnerable. By the way, I'm a huge fan of The Wire. So a topic that was addressed 15 years ago about The Wire is not a cop show, by the way. If you haven't watched it, it's about the systems failure, both in from the system of media, the system of bureaucracy, the system of public service, the system of schools, and system of the federal government to stop things like drugs and human trafficking, even. Even that was addressed by season 5 of The Wire, was that those are our most vulnerable. Those are our throwaway children. Those are our throwaway people that we just don't see, but they still need care for in medical facilities. Or without an alternative transport program where people can call 911 and the paramedics from the fire department or EMS agency still go to the person's house, but they give them a better option. They tell them, well, this is inappropriate for a 911 service call to an emergency department, but let us help you make a better decision to maybe an urgent care or help you with your non-emergent medical need and give you some advice because you called us. And I was just saying this conversation to someone this morning, oddly enough, to my competitive hospital system of the Cleveland Clinics, but my counterpart, I brought up, I said, people don't call 911 because they want to be transported to the hospital. People call 911 because someone in a uniform, which means an authority figure, can come and help give them an answer to what the problem is. And sometimes the answer is not going to the hospital, as we've seen recently, actually, with trying to keep people away from hospitals initially during the COVID crisis. But all of this matters. All of this language matters. And so we really have to say with community paramedicine, what is it? There is no one universal definition of community paramedicine, and that's good. It's been designed that way. What would happen if the community paramedic program from the situation described earlier in Cleveland or East Cleveland, which is actually a separate city, which is, I think, the first or second most impoverished city per capita in the country, a community paramedic program there should be very different from that of Pepper Pike, because I believe over 90% of East Cleveland are people of color who have critical access needs because of chronic health diseases like diabetes and chronic renal failure and hypertension that comes with the environment and unfortunately heredity. You're not going to see that 10 miles away in Pepper Pike. So the needs of one community paramedic program should not look like the needs of a paramedic program just 10 miles away. So for research purposes, for this project, we had to come up with a universally acceptable construct or that defines what community paramedicine is for this conversation. So we're going to talk about community paramedicine. I want you to think about within the terms of ethics and money. We want to define it as any pre-hospital program that reduces the burden of unnecessary transports by a 911 responder and reduces the disparity of healthcare resources in the vulnerable populations of any singular given community while maintaining the budgetary constraints within that system as well, if that makes sense. So again, we shouldn't have one singular definition. So the language of community paramedicine, we shouldn't have the idea that CP means someone's in a car and they go around and they do medication consolidations. And that's just kind of pushed on us, I think, from pictures and literature. Again, you open up GEMS or EMS One or EMS World, that's always the picture, right? Someone's kneeling in perfect uniforms, by the way, and they're talking to the person and they're both sitting down on the couch talking. That's one form of it, but that's not the definitive what community paramedicine should be defined as. But all of those things have to be within those two factors because a CP program has to be driven by those two competitive factors that we discussed earlier. The financial solvency, right? Like money. Well, if I don't transport people, how am I going to get paid? Well, you have to think on a macroeconomic scale, not the microeconomic that if you call, we haul, I get paid a little bit. You have to think on a larger scale that if you were going to be if your agency wants to be a part of the medical community, the medical system, healthcare system, that it has to do its part to save money to the overall system, not just create money for oneself, but to save money for the group, for the system. And yet at the same time, expand yourself to create a system of equity, different from equality, but equity, where everybody has an equal piece and say within that community needs assessment of what a CP program should look like. And CP programs, again, should be just as diverse as EMS systems are across the country, right? So there's a small map of the different types of EMS systems, whether it be hospital-based, fire-based, for-profit, third service. And again, even within states themselves, in most states, EMS is not considered an essential service. Just fire and police are. And so even by definition, in some states and in many jurisdictions, I think in a majority of states, EMS is not considered an essential service. Why is that? Public health is considered an essential, not considered essential service, but it's provided. So we're kind of like this, oftentimes I won't say a redheaded stepchild, but it's not on par for some reason. And maybe it's because we just can't come up with the same definitions of what all of our jobs are. Sure, we have National Registry, but let's be honest, that National Registry is a money-making, they don't have any teeth, right? They can't say, they just give you, you pay them a fee so that you can have a card that'll let you work in multiple states. Well, why wouldn't we just have a national scope of practice that we all agree to and through a federal agency that overarches EMS rather than being, the basement office of the Department of Transportation. Again, I told you this is not going to be an easy topic to discuss, but that is the reality of it. There is no singular voice for EMS. We have all these organizations, NAEMSP, or National Association of EMTs, or National Registry, and National Association of EMS, or National Association of EMTs, and all these advocacy and groups that go to Capitol Hill and lobby, but there's no singular agency that has teeth to say this is the way that business is done, unlike our counterparts to the north in Canada, our brothers and sisters across the pond, By the way, I've always want to say across the pond in a presentation. Across the pond in Europe and in Great Britain, where there's an overarching national health service that oversees EMS, because when the diversity of the programs and the diversity of EMS systems also lead to the different life expectancies by region, the number of healthcare services provided and that people have access to based upon locale, and that becomes a vulnerability for people. So we really wanted to, I want to kind of, like any good research project, I want to kind of give you an introduction into the research we're looking at with that overall question, with those ideas that we just discussed about disparity, diversity, equity, and financial solvency. And so I'm not sure, did I hit the wrong button there? Bear with me. Again, there we go. So kind of go into the research here a little bit. We looked at community paramedicine from the scope that it's fairly a novel concept. It's fairly a new concept in pre-hospital medicine. I mean, heck, even the term pre-hospital medicine itself is new. I mean, 10 years ago, if you said, I'm in pre-hospital medicine, people were like, you're in what? Oh, you're in pre-med? No, I work on an ambulance. I'm in pre-hospital med. That wasn't even a term that we used. It was EMS, right? But this idea that we become more integrated into the healthcare system, we rightfully should claim pre-hospital medicine is what we are practitioners of within EMS systems. But many of these EMS agencies struggle to understand how community paramedicine can be beneficial financially and medically and even socially to their local jurisdiction. And that opacity of community paramedic programs just further prevents the widespread adoption and implementation of these programs from one agency to another. So we want to do an appraisal of the current attitudes of the efficacy, the feasibility of community paramedic programs from one part of the country to another. And when we did that, it just gives us a multitude of prevailing opinions. And now we just had to sort through all of this data. And so their value is not universally accepted. Their value being the value of community paramedic programs is not universally accepted. And the general opinion of current EMS providers' attitudes concerning CP program as a whole is just extremely interesting. And I don't think anyone's really discussed this, how we all feel about it. So this just complicates the ability to proliferate CP programs. And so when we ask EMS professionals, when EMS professionals can't understand how CP is structured, it becomes even less likely that EMS leaders can bridge that gap in the healthcare needs for the society's most vulnerable populations, while at the same time finding the financial resources to create these programs in the first place. So again, in order to find out these attitudes and prevailing ideas and misconceptions and barriers and successes within creating CP programs, we created a survey. And I just want to thank anyone in the community, in this crowd that's listening, and those that were really helpful. Basically, I gave it out over Twitter. I didn't want to do it on Facebook because on Facebook I get a really bad sampling because everyone is probably mostly local, and community paramedicine is not something that is practiced in the state of Ohio. Is not permitted in the state of Ohio, unfortunately. And so none of the programs, so if I asked some of these questions in the survey, most people would have no idea what I was talking about. So the only way to really get this survey out was through Twitter, which is more my professional social media, if you will, professional network of folks. And there's a lot of people that helped me out, too many to name, that put this survey out. And the response, we actually got 286 respondents within 72 hours. So I thought, okay, that's a satisfactory enough cross-sampling of America and EMS systems. And so we took all kinds of things into consideration. And all of this, again, is available. I'll share this all with you at the end. I'll show you how to find it. And then you can send me hate mail on this presentation in the paper. But we broke it down by U.S. region because I didn't want any confirmation bias. I want a bunch of people in Ohio and this portion of the country in the Midwest who really don't practice CP as aggressively as they do maybe in the southwest part of the country. So I need to get a nice sampling from across the country. I also need to get a nice sampling of the different types of EMS systems, right? And by the way, if I say firefighter, I don't want anyone getting offended. That's just most people in Ohio. That is the very, very prevalent EMS system is fire-based, and I recognize that. So here we just say it interchangeably. If I say a firefighter to someone like I'm at a cocktail party because I'm like a social butterfly or something like that, oh, what do you do for a living? I'm a firefighter. Everyone understands if you're not, even if they're not in the business, that you're also a paramedic. That's kind of the vernacular here, and so I will use these terms interchangeably. I don't want anyone to be offended. But we did look at service type, right? Are you fire-based? Are you hospital-based? Are you private-based? And that was a big deal because we're talking about money, and private businesses are a for-profit business, right? They have shareholders they have to answer to. Or are you a third service, very much like Cleveland, Denver, Richmond, Austin, all these wonderful, huge third services out there that do astounding work, even though they're not fire-based, and there is no difference. But we need to take that into consideration. We also need to take into consideration, like, to get an idea of who our respondents are. What is their role, their rank within the structure, the quasi semi-military structure of public safety agencies, whether it be, again, third service or even hospital-based. There's a rank system of within EMS, within this public safety. And so I would just share some of the overarching, like, to give you an idea of what we got. So when we look at these answers, you understand not what the answers are yet, but you understand who the respondents are, like get a good idea of who these people were. This is just completely, like, we had 286 respondents, and like, look at this. This is like, what a great spread. I couldn't ask for a better spread, really. To almost have, around, 25% of within each of the generally acceptable four areas of the United States geographic locations. I didn't mind getting the Midwest is a little bit bigger because majority of the population lives within what we consider within those states. It's a big chunk of the population. Whereas Northeast, there's a lot of the smaller states up there. We looked at the types of agencies. So again, to give you an idea, 39% being fire-based, which sits with national data that most EMS services that do 911 service directly are fire-based. And third service and hospital-based came in second and fourth, respectively. And private ambulance or for-profit companies were considered in there too. And these were all very important for us to look at. And finally, we want to look at what the roles are, because if we're going to look at perspectives and perceptions to community paramedicine and how those create barriers to adopting community paramedic programs, it was really important to understand from what lens are you looking. Are you looking at from, hey, I'm on the task or tactical level, or are you at the strategic and operating level of your organization? And so when you look at it, like, well, man, that's your data is tainted. 70% of respondents were frontline responders. Yeah, so are about 70% of the EMS workforce is frontline responders. There's usually more troops than there are generals, right? So if you look at that, there's a whole bunch of soldiers there, and then we got a smaller officer corps, and then we have an even smaller chief and executive officer corps to go along with it. So I was really happy with that stratification of ranks within this. And then we had a whole bunch of very smaller, and we kind of lumped those into those three major categories, which I'll kind of show you here later. Let me ask like an overarching question here and I wanted to share with you. Because if I'm going to start digging through the data and I want to know your attitudes on community paramedic programs, I got to know, well, are your attitudes coming from not just a place of rank and geographic location, but like what you currently do? So about 25% of an aggregate of all those different types of agencies together have some type of community paramedic program, or what they consider a community paramedic program. I don't care what it actually does, as long as it's a benefit to the community, it's outside of you call, we haul, and saves dollars to the healthcare system, then it's a community paramedic program, and we kind of define that up there for them. So about 25%. A third of the agencies in this country do not have an EMS program. And another 10% roughly don't, but they're kind of working towards it. And then, unfortunately, almost 25% of communities out there said that, hey, we know about it, but we ain't buying what you're selling. We're not interested in community paramedic programs. We understand that it's supposed to be the savior of the EMS service, but we ain't interested. We ain't buying what you're selling. And we're going to really dive into some of those perceptions here very shortly. So this is a picture my wife took of me when I took all the results and put them up on a blackboard, and went insane for about 2 months trying to piece it all together and what it all meant. But what I really want to focus on are advantages and barriers to community paramedicine. And so this is a part of our survey. If we're going to understand who you are, we're understand where you're coming from, where your organization is coming from, based upon all those, what are the advantages? Like, why should we be adopting CP programs? And these are great. So 90% said that it connects patients to resources other than the ED. Just remember these, especially when we talk about these advantages versus barriers. 90% says, yeah, the advantage of why it works is because it means we don't have to take people to the ED. 9 out of 10. And tied for second, and by not taking people to the emergency department, that saves healthcare dollars. And probably from the chief's perspective, and the front line too, it releases the burden on frontline providers. It prevents burnout, it prevents wear and tear, sick time leave, taking people to the hospital that don't need to go. Like, everyone gets in this business because they want to make a difference. I tell all my young guys, I say, listen, throughout this career, at the end of every day, you will have exchanged an irreplaceable part of your life for something that is the greater good. The decision is yours whether or not it's a fair trade, right? You can either go out there with a smile and make it a fair trade, making the world a better place, or you can be grumpy and be a bastard, and it's going to be miserable, and you're not going to last long. But a lot of that has to come down to this burden of the increasing role of the increase in geriatric population, the increase in vulnerable populations, people just using EMS because that's what generations have done. It's what EMS, what it's shown on television. You call, we haul. They've never said they weren't taking before. I cut through traffic. I can get to the hospital. I can get moved to the front of the line, so people believe, right? And tied for number 3 was educate citizens on appropriate medical resources. That's huge because we're talking about disparity and balancing that with money. So if we're going to talk about disparity and we're talking about medical literacy, if we can, I don't know if educates is the right word, but how about instructs citizens, engages citizens on appropriate medical resources, or outside of the emergency department? Almost 2/3 of the respondents, almost 2/3 of almost 300 respondents said that was like one of the biggest advantages to CP, right? Saves dollars, connects people to other resources, and educates people on those other resources. It's all creates a healthcare savings to the dollars. But on the flip side, the top 3 barriers, one, current reimbursement models, right? They're prohibitive. That scheme of you call, we haul, right? I mean, if you're a fire chief and you're fighting for budget dollars against everything else and tightening, tax dollars and decreased revenues in most cities, reimbursement's a big issue, right? It should be. And then when you pair it up with, well, I don't have enough personnel in my agency, as it is, to like be NFPA 1710 compliant, right? With 4 guys in every engine and 4 guys in every truck, let alone manning EMS, which is really not an essential service per law. But that's not me saying that before everyone starts breaking their computer. I believe EMS is the biggest value that the fire department gives, or that any agency can give to the community. Like when it comes to we just have a huge impact. Like I tell everyone, fire-based for fire-based EMS, like EMS is our biggest community value. It's the biggest impact that we make every day, right? Kind of goes back to the whole thing I just said about you're going to exchange a part of yourself, might as well make it a fair trade. So give it some value. So we don't even have enough personnel to fill rigs, let alone to have the reimbursements aren't there to find those people, to make it an even trade financially between having enough personnel and getting reimbursed to have those personnel to fill these roles. And 48 or almost half of the respondents said there's just a lack of support or interest from the administration of their agency. And some of those people are saying that were those chief officers, I'm sure. Interesting enough, the other big ones were uncertainty and legal ambiguity, and I can understand uncertainty. Whether if you play stocks or you're a betting type person, like uncertainty, nobody likes that, to not know what tomorrow brings. And I guess that's probably why we're all at the EMS Leadership Summit. We're trying to prognosticate the future. And I'm hoping that this conversation we're having, this one-way conversation of you listening to me, is making your eyes open to um, that. Yeah, it might be uncertain, but we have to take action, right? Like, if you're a combat soldier, like that there's always uncertainty, but doesn't mean you should freeze. You should always be moving, and uncertainty is what kills. Or I'm sorry, freezing is what kills. Uncertainty is always there, but maintaining a stillness is what can kill you. And so we have to accept that within this job is uncertainty. It's uncertain if we're going to get a fire. It's uncertain if we're going to get a full arrest that day, right? So we should be dealing with uncertainty. That's basically our careers are built upon uncertainty. Nobody knows when they're going to have a fire. Otherwise, we wouldn't need a fire department. No one knows that they're going to have heart cardiac arrest. Otherwise, they just wouldn't need us. They just go to the hospital an hour beforehand. And the legal ambiguity, right? And I think these were the two biggest. And legal ambiguity, I think COVID has like opened up our eyes to like the idea of not everyone needs to go to the hospital. Like, it's kind of if the CDC and the state EMS agencies and medical directors didn't say like, don't bring people to the hospital for tests, like fire departments and EMS agencies would be transporting people to the hospitals for just getting tests, regardless of the level of exposure during COVID, and we would have huge issues. And that legal ambiguity, just the legal ambiguity of can we or can we not do this? Of course you can, if it meets the benefits and benefits the people in your community. Who's going to fight you on this, right? I mean, take action and move forward. There should be no legal ambiguity to this. There have been, when I worked at City of Dayton, our medical director, Randy Marriott, this was like 2001, came up with the alternative transport protocol. He had like 17 things on the list. Says, I do not want to see the Dayton Fire Department, arguably a great, one of the greatest agencies in the nation, as far as a fire-based EMS system. Very progressive both on fire and EMS. But I don't want to see you guys wasting your time transporting like these 17 things, like STDs, a toothache that with non-submental radiating pain, just it was STDs, cough and cold from someone else that they got it from someone else in the house. They had it for X amount of days. But he said, you're not going to transport these people anymore. And if there's anything on the list that I can't, that you think would meet these type of parameters, give me a call. By the way, small funny story. The first day he rolls that out, I'm on a medic unit. First call we get in the morning, a guy says, yeah, I have a pain in my buttock. Just like that. I have a pain in my buttock. What's wrong with your buttock? Well, I had surgery 3 days ago, and I ran out of I need like some ibuprofen or something. Dude, here's $1 from my pocket. You can go to Dollar Tree and get that, type of thing. But I was like, hold on. So I called, the hospital, and Dr. Mary actually picked up. I said, hey, doc, this isn't on your list of 17 things, but what do you think of this? Like, don't bring them. Just explain to them. And there's like a script. But there is legal precedence that just because someone calls 911 doesn't mean they automatically deserve. There's nowhere in the Constitution says they are afforded the right to a trip to the hospital. And we threw in a few other questions into the survey, and one of them was, do you feel that, especially those places that practice you call, we haul, do you feel that it's broken, that's not working? Something, I think we'd all agree, there's something just not clicking within our regions and within the nation that we know we can do better as an industry. And so 92.3 said, well, yeah. 92% of the people said, over 9 out of 10 said, yeah, call haul policies, that's broken. But 50% also said that community paramedic programs, no matter what type of CP programming it is, any of the ones I listed there, and there's a whole bunch more in the paper that gives examples, over half say are optimistic. The half of the people say, yeah, this could fix the problem. At the same time, almost 2/3 of the response said that no CP program options were available in their system or their agencies or their protocols. And a lot of that comes back to uncertainty, legal ambiguity, and mostly because of an imbalance between the desire to help the most vulnerable populations make better healthcare decisions than just going to the emergency department. Establishing primary care physicians and long-term chronic disease specialists versus making a couple bucks to take them to the hospital. So I want to share some more of the findings here with you. And these are really, we start breaking down the individual responses. So I just gave you kind of a macro scale, and we're going to look at some more interesting data from this as well. So we wanted to examine like how your rank and looked at kind of influenced your attitude and understanding of community paramedic programs. So let's focus in on what's Chief reading there in the middle there. What's he got? Ooh, Chief's got some data. What's Chief got? Well, we asked 2 questions within our research, 2 additional questions. So I showed you the type of people that responded to those 286 respondents, and 201 of them identified as frontline, non-supervisor EMS roles, right? So they were the people on the medic units, the squads, the ambulances, whatever you call them. 45 of those respondents said they were frontline supervisors, so lieutenants, station captains, that kind of thing. And 34 said that they were chiefs or administrative officers. And we kind of took the rest of the respondents and mixed them into the appropriate groups as well. So, and if they didn't fit, we just kind of knocked it out because we really want to focus on the differences on attitudes based upon whether you're the front line, you're in the middle, or you're a chief. And so keeping those 3 positions within the various organizations, again, no matter whether it's hospital-based, third-party, private, or fire-based, keeping those in mind, we really focused on 2 questions universally, and regardless of the location or the EMS agency type or those other factors. And those 2 questions were, regardless of whether you have or do not have a community paramedic program presently, how do you feel towards the idea of these types of programs? Like, do you feel warm and fuzzy, or is it as off-putting as jumping into a pool full of rusty razor blades, right? How does it make you feel? And the other question was, based upon what you know about community paramedic programs, do you find the concept confusing or understandable? So does it make you feel good? And do you understand why it makes you feel good, or do you understand why it makes you feel bad? And so both those questions we asked them to rate on a scale of 1 to 10, 10 being, I feel very favorable, or I have a great understanding of, in the second question, respectively. And the results showed that frontline EMS providers universally, and regardless of the type of agency, felt more favorable, gave more warm and fuzzies. They had more warm and fuzzies towards community paramedic programs than the chiefs and the supervising officers did. Okay, the average is right there, 8.2. Chief officers had the least favorable outlook towards adopting or least favorable outlook towards community paramedic programs. However, at the same time, it also appeared that the higher the rank you were within your agency, the less favorable one felt towards community programs, but also you also stated that you understood them more. So look at this inverse, right? So fire on the left side, fire chiefs and administrators felt less warm and fuzzy towards community paramedic programs than the frontline providers, who felt more. But at the same time, the chiefs felt that they understood community paramedic programming more than frontline EMS personnel. So they understood it more, and the more they understood it, the less favorable they were about it. Whereas frontline providers said, hey, listen, I feel very good about this, but I also don't feel a whole lot really well about this. Now, I notice, if you might notice, that the supervisors and officers within that second question on the understandability, right? 10 being that's more easily understandable, they were at 7.1. How do I explain that? And I'm surmising here, but when I looked at it, I thought, well, community paramedicine is a fairly new concept. And those that are officers and supervisors have been in EMS for probably 10 years to 20 years, and that, or 10 to 15 years. So CP, when they went through paramedic school in their initial educations, this was not part of their training. They did not discuss this. So people that are coming up into the frontline personnel, those that probably have, just a few years on, less than 10 years, haven't made rank yet, this was a part of this. Community paramedicine was always a part of the conversation from their initial training. So I think over time, if we redid this survey in 10 years from now, we would find that those that are frontline EMS personnel today are tomorrow's supervisors that those numbers would change. They would. So I think it's a generational thing. Let's see what else we're looking at here. So again, not slamming like administrators or anything, but like they're the ones that hold the purse strings. So we looked at the data, and earlier we looked at like those top 3 barriers, and that was an overall like regardless of rank. But when we isolated chief officers into how they felt about community paramedic programs themselves. So given that fire-based EMS systems are the most prevalent in the United States, the data was further evaluated and found that 71%, about 15 out of 21 of the fire chiefs of the fire-based EMS programs indicated that community paramedic programs were financially beneficial to EMS. However, those same respondents that indicated barriers to establishing CP programs in their jurisdictions, and they're the ones that have the authority to establish these programs. Again, they overwhelmingly said that they were the ones that said that it was the current reimbursement model that was prohibiting them from establishing these programs within their agencies. And that I can understand that. I really, so that is a huge issue, really, when we look at it. And finally, over here down on the gurney, they're about to deliver some data to the hospital in their EMS scrubs. I love these stock photos. I really do. They're great. But we asked the current state of community paramedic programs. Again, I told you we don't want to pull bias, right? So like if you asked someone in Northeast Ohio or anywhere in Ohio like about community paramedic, they're like, what's that? But if you went down to somewhere, say like the Midwest, or I'm sorry, like the Southwest, there's more prevalent. So when we broke it down from not just region, but the type of system, whether it be fire-based, hospital-based, private for companies or third service, we asked several hard-hitting questions. Like, are you currently doing community paramedic? Are you not interested in community paramedic? We don't have one, and we're not interested. Look who said the most. 98 of the 286 respondents over there in the grand total on the right stated that they are not interested in community paramedic programs, and the majority of those were fire-based systems. The fire-based systems right here were all like, hey, we're not currently interested in this. And I can understand that it's a dual role, but it's not just a fire-based EMS system, because I know that some folks are like, I got your fire-based EMS systems, welcome to third service world. Third services, they're just, when you really take the percentages of this, it's not like they're all jumping on community paramedic programming, and leading the pack nationally. So again, the overarching themes of money and ethics. The issue is that money often costs just too much. And so, money is really at the root of many of the issues surrounding community paramedic programs. And there is a credible amount of research to support this, including the survey conducted just for this research. So what we found was many chief officers have indicated that they believe that transporting patients, regardless of the lower level of acuity of the patient, is most financially successful model for their jurisdiction, right? It's not financially good for the system as a whole, but for my piece of the kingdom, for my little area, it's like that's the best thing. You call, we haul. That is the most successful, best thing that'll ever happen to us. But they also at the same time admitted through the survey that, but we also recognize for the system as a whole, it's not very good. So when everyone's drinking from the same tap, again, the money eventually is going to run out, and we basically are all a bunch of Scrooge McDucks sitting there counting our money, realizing that everybody else is going poor, or the whole idea like, oh, I got mine. Again, yeah, it's good for me, but it's not good for the system, but it doesn't matter because I'm just taking care of my little area, and we're doing okay now. But again, we talk about uncertainty. We really can't say, is it certain tomorrow that this tap won't be turned off? And we see it coming, like ET3, right? The federal government is trying to get involved in this with this issue. And I can understand from a fire chief's perspective, like it's a good thing, like it's good for me, because a moderate-sized city of about 50,000, they can accrue about $1 million annually in EMS billing fees when you go through the formulary established by Medicare. That's not in Medicaid and private insurance, and those fees are structured by HHS, and they established those basic rates. But we know even the New England Journal of Medicine stated that that the promotion of community paramedic programs as a way to save millions of dollars just to regional EMS systems, and again also to billions across the nation. And that was done by people with many, many more initials after their name than mine. But it is not just like this novel idea I've come up with myself. But even the federal government again is getting involved with ET3, and I'm not, I almost feel like the federal government got us in this trouble in the first place by allowing this almost double taxation, if you will, right? Like 20 years ago, 30 years ago, people paid taxes, you got fired in EMS, they didn't charge you. And then all of a sudden, the federal law was written that, hey, well, you EMS, and even though you've already paid for this once through your taxes, you're going to pay through it again through the insurance. So, and it's going to be like through your federal and state, systems or private insurance. So people are like, it's a double taxation. So I don't trust the government with ET3 per se. I think it's, again, given an overarching, like this is the model that will fit every community, won't fit, the same way. Like you're taking this pre-packaged program and saying it's going to work everywhere. It's almost like Leave No Child Behind, which again, like that was season 4 of The Wire, looking at the idea that school systems and teaching to the test and like this cookie cutter idea of that one shoe fits all or one size fits all, it just doesn't work. So ET3 even has its inherent issues because they're like talking about, well, instead of taking the people to the hospital, the emergency department, you can take them to their doctor's visits, and all of a sudden municipal 911 systems have turned into provider rides and things that public transportation and private wheelchair vans once did. And again, we really have to put people first because EMS has become this primary healthcare access point for so many. And by the way, so this is like the 3rd time I've taped this because I keep screwing it up. So I can't remember if I told this story or not, but I met a guy and he didn't have a primary care physician. He just kept going to the hospital all the time. And I was outside my district. I just gotten transferred, and I met this guy, and I said, well, who's your primary care physician? Trying to start a dialogue. He goes, Dr. Metro. I was like, Doctor, and I realized, oh, Metro is the county-run hospital in our city. Like, basically, Dr. Metro is whatever doctor's on in the emergency department. He's, EMS has become the primary healthcare access point just to get to your Dr. Metro down the hill, and so the many of people that we need to put first are those that are the most disadvantaged in our nation. We need to give them critical access or access and instruction into other ways to access healthcare system to help them navigate, whether it be engaging with them in a blood pressure screening in which you can work with your local healthcare agencies and healthcare resources to bring literature and have like cool conversations, not like overarching, hi, I'm a physician, I'm gonna use big words to confuse you, but like to talk. Again, EMS is like this, again, professional / blue collar industry where we walk to thin lines. We have advancing medical education. We have, I'm a frontline firefighter with a master's degree. Like that wasn't a thing 20 years ago or even 10 years ago. You see that more and more often, this idea of advanced degrees within our field, whether it be bachelor's or master's degrees for frontline providers, and that's a whole nother argument. But this notion that we walk the professional world and at the same time we can connect with people at the street level, that's these programs, all that we all listed earlier, that meets the needs of the various communities. And so we have to have this cultural shift that will drive us away from the abyss. And the abyss is that we're going to keep doing this. Again, definition of insanity is doing the same thing over and over and over again. Like you call, we haul, you call, we haul. Eventually, someone is going to get wise. The money will run out. The fruit will disappear from the tree. Whatever analogy you want to answer or to have, this is not sustainable. We cannot all sit in our silos and collect fees when the system, we're all bleeding the system out, in our own, the EMS system is like dying by a death by 1,000 cuts, and each of us is cutting a little bit on the body. And We don't recognize that the whole system is bleeding out, because all we see is we're getting our little bit of sweet blood from it in our little area, our little jurisdiction. So what happens when we take financial like leaps of faith and we put our disenfranchised and vulnerable populations first, which I think we all want to do, but it's hard to find that balance. And so, what does that look like when money and people collide? And I think one of the best examples, and one of the easiest, and I don't work for Houston, but when I read and continue to read about the successes of their Ethan program, which stands for Emergency Telehealth and Navigation. If you haven't heard about this, Houston Fire, it's a fire-based system, is the fourth largest fire department, I believe, in the country. And so what they want to do with this program is they wanted to reduce unnecessary transports to emergency departments by their EMS squads and 911 services, and while at the same time trying to achieve cost-saving results to the fire department and the overall healthcare system, and refer patients to still get medical care, but give them better options than just the emergency department. And the results for the program were really showed a reduction in unnecessary EMS transports by, like, I think it was almost 81%. I don't know if I don't have that up there, but I think it was about almost 80%. And the crews were actually able to turn, for these low acuity calls, they averaged, the average time for those return to service for those types of calls was 27 minutes versus a normal 83-minute turnaround time for the more traditional you call, we haul, which they used to do before. So that's a reduction in 56 minutes. And if time equals money, these were crews that were fire-based. They had dual service. They had high call volumes in these vulnerable populations, in these poor districts in the city. They had increased, fire in these districts. And so these were valuable combat assets that they needed for fighting disease, poverty, and fire within the community. So they were able to save quite a amount of time that they were out of service. And a more concrete evidence of the healthcare savings from the Ethan program was also observed. The Houston Fire Department found that the low acuity 911 patients who are transported in the current model cost of overall healthcare system, it costs overall healthcare system. It costs about $2,400 per 911 encounter. Let me take a sip of water here real quick. Sorry, that may sound weird on the thing here, but in a more traditional, it costs about $2,400 for the you call, we haul system. Hey, you got a low acuity issue, hop the ambulance, let's take you to the hospital. It costs the system, not just EMS, but the hospital, the taxpayers, the reimbursement model, whether it be Medicare, Medicaid. It costs us $2,400 for each one of those encounters. But this new program, patients who participate in this Ethan program, their overall healthcare system cost was about $450 per 911 encounter. And again, that's also cited in the literature, which I can share with you here. And so that's just one system at a time. What about tackling one disease at a time? What if a major hospital system tried to work with EMS agencies or agencies in their jurisdiction, just one disease at a time? And so let's take a look at a prevalent one, and that would be congestive heart failure, right? Because the Ethan program that addresses frequent flyers who do have complex medical issues that can be handled outside of emergency departments, but they don't know that because there are issues with medical literacy, transport issues and all that, and the health disparity, that 911 becoming their access point. Our senior citizens also have these chronic health issues, and one of them, again, is congestive heart failure. And so an example of a community paramedic program that can adjust for this would have to take into consideration a multiple of factors. But I'll just give you some facts here. According to the Healthcare Cost and Utilization Project at the federal level, congestive heart failure costs the healthcare system about $10,000 for every congestive heart failure patient that is admitted to the hospital. Costs the healthcare system about $10,500. We'll just say $10,000 so I don't like go crazy trying to talk here for an hour. But I'll give you an example. So in the Cleveland Clinic, we have, I think, 17 emergency departments throughout just Northeast Ohio, and we treat roughly about 2,500 cases system-wide of congestive heart failure each year. So the total amount of healthcare dollars expended on just these 2,500 patients per year is about $26 million annually. So, however, according to Medicare, all Cleveland Clinic facilities have an average readmit rate of about 22% within 30 days. And of course, we're aware that these readmit rates, there's penalties for us. So public and private medical insurance by law, they don't really have to reimburse hospitals, not just like I'm using clinic as an example. They don't have to reimburse hospitals or let alone EMS for anyone who's readmitted for patients if they're readmitted for just this one disease, congestive heart failure, within 30 days of their last admit. And so at the clinic with a 22% readmit rate within 30 days, that's about $5.8 million just that we're losing in unreimbursable health care in just one disease alone in one city in the United States. So community paramedical programs are really a key dimension in preventing this multi-million-dollar loss to a local healthcare system. So if we could allow local cities to operate community paramedic programs to follow up with recently discharged patients who present with chronic illnesses like congestive heart failure, the results of several large studies show that about 20%, there's a 20% reduction in readmittance within 30 days. And that is a program that currently Cleveland Clinic does have in Northeast Ohio, where we are working with some of our fire-based EMS agencies to visit patients once they're discharged out of the hospital to follow up with them. Again, what we found is that medical literacy. Our paramedics will follow up with patients after in order to prevent them from being readmitted, and like, hey, you can't, eat all this salty food. And they're like, well, the doctor didn't say anything about salt. They said sodium. Again, like to you and me, that seems like common sense. Or what about this one? And I see this a lot. Physicians will discharge someone out of the hospital or even out of the emergency department too, but they'll discharge them from being admitted or down in the emergency department, and they'll give them a script and they'll say, go get this filled and everything when you're discharged and everything will be okay. But what they're not considering is that these are socially vulnerable people. They're elderly. Probably they live in they might live in a high-rise public housing or low-income unit. On top of that, they probably don't have a car. They use public transportation, and they live in a neighborhood that has a food disparity, a food desert, and doesn't have a convenience store or a CVS or a Walgreens or a Revco or whatever your local pharmacy is in your area. That just is not a part of their neighborhood, and because of a variety of reasons, that those stores don't exist there, and that's a whole nother social issue and ill that we're not going to get into. But so they're discharging patients with instructions that those patients can't follow up on. So why not access those people that that already navigate those streets and those neighborhoods that the doctor does not understand exists, that they don't consider exists. They're, from their perspective, from their bias, well, everybody's got a car and everybody lives in a house, and there's nothing wrong with that bias. It's just we all have that, and there's a great conversation right now in the country about disparity and haves and have-nots, and those biases, but we all play into it regardless of what side we're on. But the idea of they're releasing people into the community that can't get these prescriptions filled, and our paramedics within that program are actually finding that to be true, where people just aren't getting the prescriptions filled for that very reason. So that 20% of those lost healthcare dollars to be able to recuperate by working with our local EMS folks is a really benefit. But that's just another one disease that we've collaborated with to help fight, reduce healthcare costs. Doesn't mean that's just a form of community paramedicine. It's not the community paramedicine. It's just a form of it. And I don't think I ever published this. And maybe I will. But if anybody's interested, you can get a hold of me. We can work on it together. But I mentioned earlier Ray's work on highlighting the importance of recognizing that we're on the upstroke of the silver tsunami, and it's going to get worse. We're going to see more and more patients that are geriatric, and again, those are vulnerable populations. So this should be our next iteration as an industry to start combating geriatric falls, recognizing the special needs of geriatrics within this fast-paced world that they're not used to. But in January 2016, our geriatric patients that required EMS services and transported were about 10 points, about 11% greater than non-geriatric patients. So we had a slight, geriatric patients accounted for about 11% more than our non-geriatric patient population across the entire Cleveland Clinic system. Again, 17 emergency departments. So by the end of a small study that we did, just some data mining, from January 2016 to December of 2018, so just 24 months or so, the amount of geriatric patients are being transported by EMS was tripled to nearly 30%. And so geriatrics are outpacing non-geriatrics at an increasingly alarming rate. And that is across socioeconomic, racial, and neighborhood divisions. That is across the healthcare system. Geriatrics are accounting for more transports by EMS. So we have to deal with that. We need to address that. And we need to develop community paramedic programs to help address that before it's too late, because we can't do it during the middle of the crisis. Oh my goodness, look at this, folks. We're moving towards the last bubbles. Fooled you. No, we are. We're moving towards the last bubbles here. I went backwards, so bear with me again. Here we go. So what does all of this mean? What I want you to walk away with is we have some biases towards what community paramedicine is, and it is affecting the idea or the value that we place in the idea of community paramedicine. It is becoming a barrier to adopting community paramedicine program. We all think that they have to be these robust programs, but they can be very simple, just fixes rather than to the health, to our individual communities, rather than just transporting people to the hospital and passing that burden of fixing the system to somebody else, right? We're just kicking the rock down the road and hopefully somebody else picks it up. So again, it's a good thing that there's no single definition of CP. We have to recognize that, but we also have to recognize that that contributes to the overall confusion and misunderstanding and biases that come along with community paramedicine, and that stratifies across ranks and types of services and regions. And Medicare, I talked earlier, Medicare only accounts for about 1/3 of all the medical billing, right? So we talked that Medicare was spending $5 billion on EMS 911 reimbursements. That's only 1/3. Medicaid is another 20%. The rest is private or self-pay. That's an incredible amount of money that it's going to be very hard to track, and we really didn't do it for this research. But 50% of the 14.6 million 911 transports, therefore, based upon those numbers, is publicly funded either through Medicare or Medicaid. And ET3 may not be the answer, again, given the variety and the scope of practice, that there is no one overall arching entity similar to what they have in Canada or across the pond in Great Britain with the National Health Service. We don't have that. Again, our overarching office is, I think, third sub-basement of the Department of Transportation. Why is it there? Why isn't it Health and Human Services? Why is it not its own entity within something more appropriate that actually has some teeth to say this is what EMS looks like, regardless of where you live? There's equity in it. You can live in South Side Chicago, or you can live in Beverly Hills, but wherever you go, the EMS available to you should be the same. Where you are born should not have to play in your access to EMS, and for EMS to guide you to the appropriate resources. So we definitely, that's something that needs to be further expanded, because the American version of EMS is very different from the European version. The European models are based on the Franco-German philosophy of bringing the hospital to the patient, right? Whereas in the United States, we typically follow a model of bringing the patient to the hospital. And I can't take credit for that. That is actually in the paper, that idea. And that really struck a nerve with me. In the rest of the first world nations, they bring the hospital to the patient. whereas we bring the patient to the hospital and we wondering why our healthcare costs are so high in this country. So don't we as an industry have a moral or ethical obligation to start to coalesce our power of decision making, to find one unified voice, to stand up and lobby to say this is what we need and this is how it needs to be structured. I mean, the medicine itself can be different from practitioner to practitioner, but the systems themselves, which is not the same as medicine, needs to be the same. And of course, this leads to, within the United States, really anywhere, labor management issues. So this has to be a collaboration of both labor and management. This is not just a union issue, but we have to have collaboration with unions along with lobbyists to make sure that one, EMS is considered an essential service, that it does more than just call haul, that money, so we know that money doesn't dry up because we're doing things to reduce the overall healthcare cost to the system and not just collect money for our own silo. And again, those goes with the future considerations. There's history is just repeating itself. EMS again saved the fire service, and now it's time for community paramedicine to save EMS, which means it's going to save the fire service. It's going to save third service type of practices. It's going to save hospital-based and even private-based services because the spigot is turning off. Albeit it's very slow right now. It's hard to see. But the laws and regulations need to change, and they are changing. And again, we need to lobby for this. CP is being discussed more in the initial training programs than it is in the executive offices. So I think, over time, as people move through the ranks, CP will be more acceptable and considered because it's been part of the thought process of, the chief 20 years from now who's a firefighter today. And if that's true, the EMS students of today really are those leaders of tomorrow. So we need to make sure that they understand that EMS is not just about people, again, that people don't call 911 because they want to be transported to the hospital. People call 911 because they're looking for an answer to their problem. And if it's a medical problem, we can do better than just dropping them off at the hospital and collecting a check from an insurance reimbursement. If that's what we're going to do, I wonder, and I want you to think, can we wait a whole other generation of EMS providers to deal with this? Or are we just passing the buck down for them to figure it out, from one generation to another, which becomes systemic. It becomes a systemic issue, and that becomes an institutional issue that we see in so many facets of public service in this country at all levels of government. And should we really be doing that? So I promised you the boring read, and this is perfect for bathroom reads. I'll leave this up here for a couple of seconds as I further conclude. But what you can do is you take your camera phone. For those of you that are like me, over 40, that means you take out your iPhone or your iPad if you still have a flip phone, and you just move the camera up to this little thing on your screen. It'll take you right to the quote-unquote published version of my paper. It's a PDF. So it's universal, print it off, read it. It's about 49, 50 pages of all of this. And again, a lot more stuff that I left out. But I just wanted to give you an overarching idea of what I'm trying to discuss and get us to start thinking about. Again, this is not an easy topic. Some of us might be considering, like, what are we doing? Like, where are we going? That's that uncertainty, and that's good. You want uncertainty because it drives you to make change. So if you really have problems with me, you can taunt me and troll me on Twitter. I am at OneTallMedic. If you ask, I'll tell. I'm 6'8", so it's at OneTallMedic. You can email me at beerst@ccf.org. Dorg? Again, been talking for a long time here. beerst@ccf.org. There's my phone number. I'll take hate voicemail. And if you want to send me an old-fashioned letter, I would love that as well. That is my address. Listen, I've been doing this for 25 years. I've never lost a passion for EMS. I'm actually taking a fire department promotional in about 30 days from now, and I'm dreading it because I'm basically going to be promoting myself out of EMS. And so if this is my last hurrah, my last contribution to EMS on the fire side of stuff, I'll still be working at the hospital as the EMS manager and working for a great employer at Cleveland Clinic. I I can't stress how wonderful they are to work for, to give me the breadth and the room to explore these ideas and these notions openly and to be this creative. And my fire department to put my ideas in practice and in theory and to talk and explore and collaborate with them. Both privileged to work at both of those places, but I'm eventually going to be, if I get promoted, I have to pass the test first. Well, I'll basically be promoting myself off of the ambulance. So this might be my last hurrah. So with that, I'm glad that you were a part of it. And look at that. We are at 1 hour and 30 minutes right now. And with that, I say thank you very much. Please pick up after yourself if you're at your house. And the usual, please take evaluations. Please be honest. And I really do hope to hear from many of you and start further dialogue and conversation on this topic. Thank you. Bye-bye.